I am Kazuki Tobita from Shonan Kamakura General Hospital, Kamakura, Japan. It's a great honor to join KTRI. My case is so simple, so I'll introduce my current intervention via DRA and case presentation of CIA occlusion. This is my disclosure. The graph is the number of intervention in my hospital. PCI case didn't change during 20 years, but endovascular case increased gradually because the patient became high age. In addition, there is many patients on hemodialysis in Japan. Many CLTI cases are a big problem. Initial EVT was performed with transfemoral approach only. Large sheath was required, but increased risk of access site complication. Retroperitoneal hematoma sometimes cause shock, and pseudoaneurysm of femoral artery needs treatment. In most cases, thrombin hemostasis with EVT can help. However, Viaband stent graft sometimes needs at such a case. Meta-analysis revealed increased outcome, in threatened outcome. This study included 7 papers and 14,000 patients. A patient with bleeding has bad prognosis at 1 year. In addition, even patient with access site complication had a many high mortality rate compared with no bleeding patient. This result showed the access site complication was worsened prognosis following PCI. Previous report revealed the incidence of RAO about 5 to 10%. We analyzed the predictor of lap and beat trial. The predictor of RAO was large sheath and severe pain. In addition, large sheath was risk factor only for Japanese population. This reason was not clear, but small vessel size and hemorrhagic might be risk factor. Distal Radial approach was suggested to overcome this problem. Several reports revealed less forearm RAO rate. So we employed the RA approach from 2017. Advantage of Distal Radial artery approach was as below. We got a venous line from same arm and the patient feel comfortable. In addition, bleeding risk and hemostasis time are very low. Maximum advantage is prevention of forearm RAO. Previous meta-analysis revealed DRA and conventional radial artery approach were equivalent in terms of puncture success, hematoma, spasm, and dissection. RAO was lower than conventional RA approach. Distal Radial trial was a randomized trial of conventional radial approach and DRA approach. Crossover and spasm are higher in DRA group, but hemostasis is easier in DRA group. Probably this result reveals that DRA puncture required training or echosonography guidance puncture, and there is benefit of hemostasis. Our data revealed the forearm RAO rate was 0.4% and very few. In addition, there was no serious complication as major bleeding, neuropathy, and 1 LI case only. Difficulty of hemostasis occurred in 2.4%. However, these patients achieved complete hemostasis by Tobita or manual compression. This is key slide. Lap and beat trial revealed large sheath was a risk of RAO. However, the opposite result was achieved in DRA puncture. RAO was less when intervention or using large sheath following DRA approach. This reason was not clear. I consider that DRA has much collateral, so be more likely to benefit from antiplatelet therapy and anticoagulation therapy as heparin. RP system produced by Thermo in device for radial approach as Dr. Yamamoto presentation. But this size is 6 or 7 French. So we aggressively performed the distal radial approach at endovascular therapy due to prevention of RAO. This system has many limitations of device shaft, technical difficulty, and backup support. Then the other approach is limitation, and long shaft guiding sheath was required. So we often have device limitation and poor backup support. If we would like to deploy a stent graft, we should select transfemoral approach. And embolism is a large problem. If possible, CT image should be taken before procedure. Poor backup support is a big problem. The distance from puncture site to lesion is very far. So we should employ a technique to straighten backup support. We use hard shaft support catheter and 18 inches guide wire, and if there is margin, BBQ technique is a good technique to increase penetration force. So this is case presentation. 70 years old female, be not too tall but fatty. Risk factor were hypertension, dyslipidemia, and current smoking. We selected left distal radial artery and 6 French destination slender. I like right side approach because I hesitate radiation exposure. However, unfortunately, her right radial artery was already occluded. This is initial angiography. Lesion length was about 30 mm without calcification. In addition, I had a preparation of puncture left femoral artery in case of necessary. I started 18-inch guide wire with a support catheter. Lesion was not so hard with fibrotic plaque. So guide wire advanced to sub-intimal space. Next, we use 12-gram wire with a double lumen catheter to straighten backup support. The wire crossed to distal true lumen. However, IVAS image revealed not a good route in mid portion. So we attempt 3D wiring with IVAS guidance. 12-gram wire with IVAS parallel gradually advanced into fibrotic plaque. Finally, wire went to distal true lumen. IVAS image revealed better route compared with previous wire route. We consider less vessel rupture risk and sufficient stent dilation if we dilate the route. After 6 millions PTA, we confirmed good expansion. Misago bare nitinol stent implantation and 7 mm post-dilatation were performed. This is final angiography and IVAS examination. Stent was expanded satisfactorily, and internal iliac artery was not occluded. We finished the procedure. Procedure time is about 34 minutes. This is final slide. Endovascular therapy via DRA will be required due to bleeding risk, RAO risk, approach site limitation, and patient comfort. So I consider this approach should be mastered for future EVT. Thank you for your attention.